So I'm excited to introduce our final panel is about to begin. We'll be focusing on workforce, access, and diversity needs. And I'm honored to have our KP clinical leader, Dr. Karen Stewart, moderate this panel. So let me tell you a little bit about Dr. Stewart. She is the Chief of Behavioral Health for the Southeast Permanente Medical Group. In this role, she's responsible for development and implementation of the mental health and wellness care delivery system for Georgia's 320,000 members. Dr. Stewart is a champion of integrated mental health into primary care settings through her role as the National Clinical Lead for Collaborative Care for Kaiser Permanente. Her leadership centers critical work such as creating a zero suicide and overdose culture, focusing on measurement-based care, and providing delivery innovations like digital therapeutics. Dr. Stewart's is board-certified adult and child adolescent psychiatry, who received her BS in chemistry from Spelman College and her medical degree from Morehouse School of Medicine. She went on to complete her adult psychiatry residency and child and adolescent fellowship at Emory University. Dr. Stewart has served on the boards of trustees for Morehouse School of Medicine and the Georgia Psychiatric Physicians Association. So welcome, Dr. Stewart.
Thank you so much for that introduction. Like, I sound far more impressive than I feel on an everyday basis, so I appreciate that. Good afternoon, everybody, and welcome back from lunch. I know that after lunch, you know, all of the blood is going straight to your gut and not to your brain where we might need it to be. So if you feel like you need to rise in body or spirit to shake things off and be engaged with our panel today, please feel free to do that along the way. So, this afternoon, I am privileged to be moderating a panel on the mental health workforce with a group of esteemed panelists. As we take a deep dive into the future of mental health and addiction services in this country, it is particularly important to examine the development and sustainability of our mental health workforce. For decades, policy and workforce experts have been concerned about the shortage of mental health professionals as the need for individual needing mental health treatment rises and outpaces the number of mental health professionals available. Before the pandemic, the U.S. Health Resources and Services Administration predicted that the U.S. would have a shortfall of mental health and wellness providers of more than 350,000 by 2030. Deficits in our mental health and addiction workforce manifest in long wait times for appointments as instances of anxiety, depression, and suicide increase. We are approaching a breaking point. I feel it when I'm looking under rocks and around corners when I'm recruiting, and you all feel it when you're waiting 3 months for an initial appointment or a return appointment. Fortunately, though this sounds very bleak, we have experts like our esteemed panel working on viable solutions to help bolster our workforce in innovative ways that expand and diversify the behavioral health workforce and make access to care easier for our patients. So I'm going to start by just giving a brief introduction for our panel. We have Dr. Anna Ratliff, Dr. Parindra Khatri, and Keris Myrick with us today. I'm going to introduce each of them individually as they give their remarks, and I'll start with Dr. Ratliff. So Dr. Anna Ratliff is a national expert on collaborative care with a specific expertise in training teams to implement and deliver mental health treatment in primary care settings. She is currently a professor in the Department of Psychiatry and Behavioral Services or Sciences at the University of Washington, where she developed additional expertise in mental health workforce development, suicide prevention training, adult learning best practices, and mentorship. Dr. Ratliff is the co-director of the AIMS Center and director of the University of Washington Integrated Care Training Program for residents and fellows. Please welcome Dr. Ratliff to the podium.
All right. Thank you. Okay, I'm very pleased to be here and talk a little bit about innovation, hopefully to close the gap around behavioral health workforce. And since I'm the first person up, I always like to give a little context. I think we've already been talking about a lot of these facts today. I think it's helpful to think about the fact that more than half of the people who want care don't get it, right? So to me, that's really a very important context, and I think behavioral health workforce is a big part of the limitations in access. I also think it's important to talk about that we really have broad needs in behavioral health workforce. So these two slides are really to just illustrate. The first one was a study that looked at access to prescribers and found that most counties in the United States 96% have some level of unmet need for prescribers, which means there's not enough people available to prescribe evidence-based treatment for mental health disorders. The bottom figure is actually from during the COVID pandemic. They did these pulse surveys where they were able to actually kind of do snapshots of what is access to care looking like. And it was actually looking at access to psychological treatments or therapies. And there's also a huge unmet need. It varied across the pandemic and it varies county by county, but essentially, it's also hard to get access to like our evidence-based psychological treatments that we know are effective for our patients. So, I think it's also important as we start to talk about workforce that this isn't just specialty behavioral health providers. There's a whole continuum of behavioral health care settings where people are accessing care. Everything from community-based settings to integrated care in primary care settings to our specialty behavioral health settings. So I think it's also important. People will often talk about lack of a certain amount of workforce in a specific area, and I think it's hard to just look at one area because you really are having to look across that continuum. Because of course, if you can give more access in settings like primary care or the community, maybe that can pull some of the burden off of our specialty care settings, for example. So it's going to be really important as we start to think about workforce, what are all the levers and strategies we might be able to use? I also think it's important to broadly define the workforce. I purposely made this not a hierarchy because I actually think all of these folks contribute to what we might do in terms of increasing access to behavioral health. And these include people like our prescribers, our delivery of therapy, more formally trained behavioral health workforce. This also includes people who support patients, like their families and caregivers, other people in the community. It also includes people like our primary care workforce and other partners. So I think one of the things I really am challenging all of us to think about is who are all the people we might be able to recruit in to help us with some of this very important lack of access to care. So I wanted to give 3 specific examples of ideas because I think this was part of what we were hoping to do is actually generate ideas around especially policy levers that we might use to fill some of the behavioral health workforce gap. So I work in collaborative care. This is my area of expertise, so I'm going to talk a little bit about collaborative care. And I think this is an important strategy because I think there are several different ways we can actually increase the workforce. And I kind of created this diagram because I've been trying to wrap my head around where all the places we might have levers to improve and fill that gap, right? So the 3 areas that I'll talk about are all things that could really increase the available workforce. I don't want to in any way devalue some of the things that are also very important in retaining our current workforce. I think we are also hemorrhaging people. I'm not going to focus on that today, but I just wanted to acknowledge there's another part to my diagram here because I think those are other places that we might be thinking about policy innovations. So in collaborative care, I think one of the things we've seen, and it was talked about that is an evidence-based model, but has not had as much uptake as we would hope, or not as much as Prozac. And so, what are some of the levers that have been used to try to promote that? So I'm going to talk about those first. I think that these are really important strategies because integrated care, collaborative care is a way to teach your workforce new ways of working together so that they can expand the number of people that they're impacting. And so I will show you that on the next slide. So this is basically training in new skills, right? How can we take our existing workforce, give them new ways of working to actually expand how many patients they're able to touch or support? So in this model, just as a quick reminder, the primary care provider serves as the main prescriber, really owns that patient relationship with the patient, and they are partnered with a behavioral health care manager, often a master's level person, who has training in both psychotherapy but also in care coordination, and then often use a psychiatric consultant who has that prescribing expertise, who doesn't see patients directly, but rather leverages their expertise through that team to be able to actually serve more patients. So when I did this work, instead of seeing 8 to 10 patients in a clinic by myself, I would support 3 care managers in a day that each had a panel of 60 to 80 patients, right? You could see my work would be leveraged a lot more in that situation. So what are a couple of policy levers that have helped with this kind of structure? The first was one that was already mentioned today, that CMS started offering Medicare payment for collaborative care. These are some of those codes and their reimbursement rates. I think it isn't, a panacea, but it has offered a lot of practices, a way to practically start moving in this direction. And we've also seen that establishing those codes has led to Medicaid in many states also adopting codes or payments for this work, as well as seeing many private commercial payers also starting to pay for this work. So creating an infrastructure and a way to actually pay for team-based care, even though it's a little awkward, you're trying to use our fee-for-service system, has been really powerful lever to start increasing opportunities for this kind of care. I also think one of the things that we've found is that it's very important to support implementation. I think that is one of the reasons why it's been hard. It's not quite as simple as just prescribing a new medication, right? You actually have to figure out how a whole team of people can actually work together in new ways. And so we've seen also some legislation in that area. This year there is federal legislation trying to look at maybe increased payment rates for the first few years that people are billing these codes, for example, as a policy lever to really incentivize people to take that investment and actually start delivering care this way. The next, lever that I'll talk about a little bit is, creating new types of providers, and I think we already heard a little bit about that as something important to be thinking about when we were talking this morning. I'm going to talk about a specific policy innovation that we've been working on in Washington State. We've decided to work on creating a new behavioral health workforce called a behavioral health support specialist. This is going to be a bachelor-level provider that is trained to deliver evidence-based therapy to address common mental health disorders. They are not going to have within the scope of practice to diagnose, so they would have to be working under and closely with someone who had that scope of licensure. This has been a really complicated project to work on because we've had to simultaneously work on policy, curriculum, and practice changes to really try to foster the adoption of this approach. But I'm very pleased to say that last year the Washington State Legislature approved creating this scope of practice, and we're literally in rulemaking starting next week on what this will actually look like. And this is based off of a very successful model from the UK called the Improving Access to Psychological Treatment, whereby creating this kind of provider that had a lower barrier to get to start practicing actually has dramatically increased access to psychological treatments in their country. So I think we need ideas like this that we're bringing into the United States, and I'm really excited about this particular opportunity. And lastly, I'll just talk a little bit about how do we actually, if we're actually talking about trying to increase the number of people that are in our current training programs, what are some of the things we need to be able to do to support that work? And I'm going to talk specifically to supervision. I was the residency program director until June of this year at our university, and I can tell you getting people to supervise, we expanded actually our residency program under me. We added 16 additional psychiatry residents. It's now the largest psychiatry residency program in the country, but it was a lot of work for faculty to supervise those additional people. And so I want to talk a little bit about some policy opportunities that might be helpful to be thinking about if we're going to try to also fill up and expand the number of our current traditional programs that we're doing. The first thing is, most of the time, there's a lot of variability in how much supervised practice people need to be able to go into practice. And so one of the things our state has been looking at is, what is the variation for equivalent types of providers? For example, there's different numbers of hours that are needed to actually become licensed for a licensed marriage and family counselor compared to a licensed social worker. And why is that different? We don't actually have a lot of data on that. And so I think it's actually really important to challenge. Just because we've been doing it that way for a long time doesn't mean we should keep doing it that way. And we should be looking at those numbers. We should be looking for data to inform how long should we actually be doing, expecting people to get supervised practice. The other thing I would say is that I think it's also important to think about, are there ways to pay supervisors while they're supporting trainees? I think there's this misconception that when you have a trainee, it's going to help you be more productive. I can tell you right now, as someone who does this, it slows me down. I can see way more people by myself than when I'm training a resident. And we need to have some way to get paid for that time. Interestingly, for primary care provider, there is a primary care exception for Medicare, where even if that supervisor isn't directly with that person, they can still bill for those services. And that doesn't exist for psychiatry residents, for example. And so could we look at some of those policies that have promoted, specialties like primary care, and think about that as a way to try to create more incentives for providing supervision and increasing the number of people we're training, because I think otherwise people are going to really struggle to do that. So I hope that these were a couple of good ideas that you can take back, and happy to talk about them when we do our discussion.
Thank you so much. Next to the podium, we have Dr. Parindra Khatri. Dr. Khatri is Chief Clinical Officer at Cherokee Health Systems, a comprehensive community healthcare organization in Tennessee that is a federally qualified health center and community mental health center. In this role, Dr. Khatri provides oversight and guidance on clinical quality, program development and management, workforce development, clinical research, and clinical operations for blended primary care and behavioral health services. Within the organization, she is also the principal investigator of several research and education programs at Cherokee Health Systems, including NIH-funded All of Us research program and Community Engagement Alliance Against COVID-19 Disparities. Please help me in welcoming Dr. Khatri.
Thank you. Thank you so much. I'm delighted to be here, and I'm going to give really the provider perspective as both a FQHC, or Federally Qualified Health Center, and a licensed community mental health center, just to give you a level set from my perspective and a little bit about who we are. We are based in Tennessee in the Smoky Mountains, and we actually focus quite a bit on offering a continuum of primary care, behavioral health services. We also have optometry and dental services. As a safety net healthcare provider, health equity is kind of a running theme across everything that we do. And virtual health, training and education, we had to get into, because these are things that we needed to help us do our job. A little bit about our snapshot. We were established in rural Tennessee in 1960. We started out as a community mental health center. So it was just this tiny little open on Tuesdays and Thursdays child guidance center. And it was in 1983 that we expanded into primary care. We really did it because of patient need. No one would see our patients for medical care. We would be in these areas, and the primary care docs would say, oh, that's a Cherokee patient. They have a mental health problem. I'm not going to see them. So at the same time, we worked with the Bureau of Primary Care and started putting behavioral health providers in their primary care settings. The behavioral health providers came back and said, we are seeing just as much psychopathology in primary care as we are in our specialty mental health care. So since the early 1980s, we worked on developing a model that was very much community-based, team-based, and frankly, innovative out of desperation. Everything we've done really that's been innovative is because we've been desperate to solve a problem. We even started doing our telehealth. We're now 21 years into doing telehealth. We originally used T1 lines, and I don't know if you remember the Max Headroom, like da 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 da. That was our psychiatrist. He built our first telemedicine unit from the clearance rack at Lowe's. And now, of course, it's, we use Zoom, et cetera, but that's how we were able to get psychiatric services to the most rural areas in Tennessee. We see about 67 to 70,000 patients across 13 counties. We also have another 20-plus virtual health school-based sites. Somebody had talked about school-based in collaboration with schools. We have some counties, in fact, the county where Dolly Parton grew up, Sevier County, where we have 27 schools across 280 miles of mountains, up and down, where we provide virtual integrated services. And our population is quite diverse, believe it or not. We have patients in rural Appalachia. We have urban settings, we have homeless health, we see new Americans, refugees, and African American, Hispanic, Latino. So what I want to just convey is we have had to adapt our behavioral health services to meet a variety of populations and a variety of needs. So here's a little bit about how we have done that. One thing that has been clear to us is that people show up for behavioral health in different settings, and we can't expect everyone to fit our way. So we say there really is no wrong door. We have integrated behavioral health in primary care. We have integrated clinical psychologists, licensed clinical social workers, licensed professional counselors, LMFTs, really embedded as part of primary care. Their job is to manage primary care patients. We also have consulting psychiatrists or consulting psych nurse practitioners for the medication management and just general consultation. But we also provide what you would consider all the trappings of a community mental health center. Case management, care coordination. We have a day treatment program. We have a substance use disorder clinic and a series of them, and some are really embedded in our MAP program. We've got one embedded with our OB program, because we have so many pregnant people with substance use disorder issues. And we had to get a psychiatrist who had specialized training in management of pregnant people with psychiatric issues. Peer support has been unbelievable for us. We probably have grown that by 4 times in the past 6-7 years. And we have a number of peers. Also day treatment. And I also want to just give a shout out to individual placement and support. For those of you who are not familiar with that, that is a kind of a supported employment. So people who have behavioral health conditions can work with our ISP counselors, and we have connections with businesses, because meaningful work is actually an important part of overall health and mental health. And that's really what we see from the research. So as you're seeing, we have a continuum of behavioral health services. So what do we do? What are the different functions and roles? We have expanded quite a bit of who can do what, but in general, what we have is our specialty therapists, our licensed clinical psychologists, social workers, licensed professional counselors, licensed marriage and family therapists. Our peer program has exploded. We have peer wellness coaches, peer support specialists, peer recovery specialists. I will tell you, our peers saved us during the pandemic. We had 2 groups who saved us during the pandemic. One were our peers, The 2 was this behavioral health assistant, which was a category that we developed. We thought we developed it, but I saw, Anna, you have that, so I guess it wasn't that unique. But we needed somebody who could be the glue, help support the care plan, do a lot of care coordination. Our peer recovery specialists, our peers who are in the state of Tennessee, we actually can get them certified. So they're certified, they go through training, they have supervision. They were placed in the emergency rooms before the pandemic to help link people who had come in with overdose or any OUD issues, any SUD issues. And then when the pandemic happened, they were kicked out of the emergency rooms. They just said, we can't have people in here anymore. And then they came and just sat with our team. And they jumped in and they made phone calls. They helped triage. They were out screening. They were our high touch for our patients who were most at risk. And those were patients who had a very strong structure of support between our IOP, NA, AA, et cetera. And all of that had vanished. All of that had vanished during the pandemic. So the risk was really high. And then we have our psychiatric medication management. And as you see, we have a quite broad group of people who prescribe. And it really, I think, is grounded in our strong consultative psychiatry model, because we have OBGYN providers, addiction medicine physicians. We have primary care providers who feel comfortable, much more comfortable, consulting with a psychiatric consultant and then having psychiatric med management. I will tell you the most comforting thing that they can hear is, I'm here if you need me. I can see this patient, I can stabilize them if you need to get them back. And I think that infrastructure has been really important. So what we're able to do is preserve our specialty resources. We talked about that. We don't have enough specialty resources, so we need to preserve them for the patients who need them the most. The one thing I will add that's important is traditionally in behavioral health, it's been a one-way model. You refer someone to a specialty behavioral health provider. If your primary care, one of our primary care docs who joined us said, usually it was like sending a message in a bottle. I never knew what happened. I didn't know what meds they were on. I never even know if they showed up unless I asked again and again. So what we have learned to do is be very intentional about the bidirectional flow. Because when people stabilize, because believe it or not, having a mental health disorder is not like a sentence for the rest of your life. People can improve. This is an undulating course that people experience. And when they are more stable, you have to intentionally reabsorb them into either primary care or a setting where you don't need the same level of intensity. This is really hard for people who have gone through years and years of training to absorb. Because they will say, well, this is my patient and I've stabilized them and it's now an easy patient for me. But the reality is we need to open you up for the next round of patients. And that population health mentality has been something that we have had to train in our staff, because most training programs, including when I went through training, only train you to work in your silo and to think about your caseload. Now, when we get providers, we have to basically give them a crash course on population health. And what does it mean to work as part of a team? And how you can contribute to the improvement of an entire population, not just the people who you like on your caseload or your schedule. And that is very challenging. And we have to really think about that as a culture. And then frankly, we've developed some pretty robust clinical analytics. So people know, you've seen this person for X long. This is how their measures look. Do you really need to keep seeing them, or can they be transitioned to another group? Okay, so in terms of workforce recruitment and training, we realized 40 plus years ago. We are a nonprofit. We're in many of our settings are not the most desirable settings for people to live. We don't have people knocking down our door wanting to work with us, at least at that time. So we started our own training programs. It was the most selfish thing that we could have done. And it is the most selfish thing that we do, because so many of our current staff were trained with us. It is the best job interview in the world. And so we partnered with multiple programs, multiple academic entities. You'll see nurses, family medicine docs, psychologists, clinical social workers, you name it, nutrition students, we have it all now. And I will say another thing that we had to learn is we had to build in boot camps for people who were retraining in the integrated care model. So particularly, like, for example, our psych nurse practitioners, most of them have not been trained. So they usually don't even write prescriptions for the first couple of months that they are with us. They train. Our director of psychiatry has created her own little boot camp because the investment early on is worth it. We don't really want them to learn that much on the job, because if you stumble too much when in integrated care, you lose credibility. So we create those, we really create a lot of infrastructure and support. We've learned it because we have battle scars. Every single time, we have shortchanged training. And we have shortchanged training a lot because we just want to get someone in the office, get them on the floor, get them seeing patients. But every time we've done it, we pay for it. Every time we've done it. So we've said invest early on. And as you can see, what we've had to do is also build an infrastructure around what we consider professional quality of life. So that's been really interesting to do in an integrated setting. So you have our ballot groups, if you're familiar, they're actually co-run by one behavioral health provider and one primary care provider. This is probably the slide that I want to drive home the most in terms of meeting the need of the workforce. What are the facilitators and what are the barriers? The facilitators are so much of what we've talked about. We've got a diversification of a workforce. We've expanded what people can do in an acceptable and appropriate manner. We are seeing more uptake of integrated care, and we're starting to see some movement. You know, we talked about value-based payment. We're starting to see some movement in advanced payment models. And for us, as an FQHC, we track, anyone who's familiar with UDS, the Uniform Data System, we track like 60 plus metrics. We also have to track metrics as a community mental health center. We're also an alcohol and drug treatment center. When we look at those metrics, even all the medical metrics, we assess them based on the performance of the team. So if you're a psychiatrist or psychologist or any behavioral health provider, peer recovery, you get those metrics for diabetes management. You actually get them for, breast cancer prevention, mammogram. This is a team outcome. So we want and need better behavioral health outcomes, but we actually look at it as a whole. The barriers drive me crazy. Reimbursement has been stagnant. We have commercial contracts that the rates have not been updated since 1994. 1994. It is like, I was going to say it's like an act of Congress, but it's very hard to renegotiate your commercial rates. The bureaucratic complexities are very challenging. Just getting behavioral health providers credentialed is hard. In the state of Tennessee, for Medicaid, if you're FQHC, you're supposed to get credentialed, fast-tracked, within 30 to 60 days. That is not enforced. So we have psychiatrists, psychologists, clinicians. We have people who we've had on staff for 4 months, 6 months, 8 months, a year and 2 months. where they are not credentialed. That credentialing is a payment issue because any claim we submit will get denied. So when you talk about access, you also need to realize for many, many years, we were seeing people no matter what, but we were not getting paid. And payers would say, hey, we don't have to credential them. They'll see them anyway. And, you won't get paid. But for a nonprofit or frankly any health system, you can't keep doing that. It's not sustainable. But we are having significant barriers with credentialing. The devil really is in the details. And I'll wrap up with just a story just because it came to me when Dr. Pincus was talking about the 7-day follow-up, hospitalization follow-up. So here's an example of when we tried to be creative. We worked with different psych hospitals, but we had one psych hospital that agreed to let us set up a telemed unit in their hospital. And this was before Zoom, this was before the pandemic, this is when we were using Polycom. And we set up block scheduling, so when someone was being discharged that morning, they're getting discharged from the psych hospital via virtual health. They would see the case manager, the therapist, and the psychiatric provider. We had 100% follow-up for that 7-day for that hospital until someone found out that if we billed for our outpatient follow-up services, the hospital was not getting paid for that discharge day. And then once that was identified, they said, you can't be here anymore because we don't get paid if you see them that day. So when you talk about bureaucratic complexities and all these issues, and particularly within the context of payment reform, the payment and incentives have to be aligned across all the continuum, and that has yet to happen. So I hope what this has done is given you a little bit of a sense of how we have had to be creative with our workforce in training, education, and development, but also some of the real nitty-gritty challenges that we are experiencing as a provider, really trying to meet an almost unrelenting demand for behavioral health services. Thank you. Thank you.
Thank you so much for outlining some of the challenges of managing our workforce. To round out our panel today, we have Keris Jän Myrick. Keris Jän Myrick is the Vice President of Partnership of Inseparable. She previously served on the board of and is currently a policy liaison for the National Association of Peer Specialists and the Board of Directors of Mental Health America. With over 15 years of experience, she is a leading mental health advocate and executive, known for her innovative and inclusive approach to mental health reform and the public disclosure of her personal story. Please welcome Dr. Myrick. I'm sorry, Ms. Myrick.
Oh, you can call me Dr. Myrick. I'll take it. Okay, y'all still with us? Yeah? Oh, I'm not using this. I'm using this. Wait, what? You're still with us? What? I didn't hear anything. Then you're going to make us do the work. You might as well participate, right? All right, so I'm going to talk to you a little bit about peer support and the work that I've been doing in the area of peer support over the past, gazillion years or so. And I wanted to start off with a little snippet from Dr. Miriam Delphin-Rittman, who is the Assistant Secretary for SAMHSA. Hopefully this works.
To truly meet the needs of individuals that are having challenges. And, I love that mantra, nothing about us without us. When I was commissioner and in my work now, I try to have that at the center of our work. And so the recovery office is very much about that, involving individuals with lived experience in the work throughout SAMHSA. and coming up with strategies and approaches to advance recovery from an individual program perspective, but also a system perspective as well.
So out of the Office of Recovery, there's a lot of work that's happening around peer support. And so I like grounding it in her vision of what the office is, and point of disclosure, that is her on my podcast. So that's point of disclosure. So how many people are familiar with what peer support is? Okay, and you actually explained it, so I am done. I think that was my presentation. But basically, peer support is somebody, of course, with lived experience who uses that experience along with training in order to provide support to another. It can happen by being a certified peer support specialist. It could happen by being a mutual aid like AA, where you don't need that kind of training working in the community. It's been very confusing to the field about exactly what is peer support, who does peer support, who supervises peer support. So before we can even get into what may be some policy recommendations to advance, I think it's also important to understand a little bit about where we were and where we are. So because it was really hard for people to kind of wrap their head around what peer support was, back in I believe this was 2017 or 2018, we actually, at SAMHSA, which is where I used to work, by the way, we created through the Bringing Recovery Supports to Scale Technical Assistance Center strategy. That's the government for you, brass tacks. We created these value of peer support. It's very hard for people to kind of wrap their head around advancing peer support because they didn't know what the evidence of peer support was. So we would get called a lot and, what is the evidence? Can you send me a lit review? No, I don't have time to send you a lit review. But what we do have time is to give you these kind of infographics that talk about peer support, basic peer support, mental health peer support, addiction, and then also family and caregiver peer support. So if, I want people to be able to access these documents should they need them. They're really, really helpful, and I've actually seen legislators use them when they're trying to advance legislation related to peer support. So on the front side, it talks about what peer support is, and on the back side is a mini, if you will, lit review about what are some of the outcomes related to peer support that are evidence. Well, I would say based on evidence. I don't know that evidence-based is quite the right word. So these came out in 2018. And also in 2018, because of the 21st Century Cures Act, the GAO examined mental health peer support. And, really the essence of why that happened was the belief that Medicaid and the government should not be funding peer support. That's actually why they asked GAO to do the report. And actually what happened is the GAO found that there are 5 leading practices for certifying peer specialists as they looked across the states at that time. And that was put out to the field. And then in 2019 was a separate report on SUD, recovery, coaching, and Medicaid. Whoops. I'm like skipping ahead of myself, I believe. All right. So also in 2018, SAMHSA released the National Core Competencies for Peer Supporters, again, to help the field have a better understanding of what are some basic guidance that we could provide across the states as they started to set up their certification practices. In order to bill Medicaid in 2007, CMS, gave guidance to the states about what the things were needed in order to bill Medicaid for peer support. One is around having core competencies and training. The other is around supervision. There was also what is the age range of a peer supporter and what are the educational backgrounds, prerequisite educational backgrounds. And I'll talk a little bit about that. So in 2018, SAMHSA created these core competencies for peer supporters because of the variability and to help states kind of align a little bit better. They didn't have to undo what they were doing, but certainly to align. So one of the things we've never understood is who are they, what are they doing, where are they? We still kind of don't know that, which I think is a bit of a barrier. How do you advance something when you don't know how many there are and where are they and what do they look like? So we have a general idea that peer supporters tend to look like the communities they serve. So I think when we're talking about equity issues, when we're talking about being able to see somebody as a person with lived experience, see somebody who looks like you, who's been through what you've been through, especially if they're not providers of colors, for example, peer support is one way to think about advancing the diversity of the workforce, but quite frankly, we don't know exactly how many peers there are across the country. We think 20,000 from a recent study that is still, it says between 20 and 30,000. Well, that's a big sort of plus or minus, right, of 10,000, but we don't exactly know the diversity of this workforce. So this is actually a KFF link that I think is really great for people to look at. It provides data that you can search state by state, information about Medicaid and peer support. Now, not all peer supporters bill Medicaid, so this is giving you a slice of the pie. You may have peer-run organizations that are grant-based, that are funded by philanthropy. They may not be billing Medicaid. And then you have also your mutual aid like AA and the like that are not captured up in this, but this at least gets us started in looking at what states are Medicaid reimbursable and what aren't. And I actually was doing this presentation for, I think it was CSG, Council of State Governments, and there's kind of one mistake here, so that's okay, but basically there are 41 states where peer support are covered, there are 5 that they're not covered, and that there are 4 in which they did not get any response. Now, what was interesting when I gave that presentation, I kind of wanted to know, why aren't they covered in a particular state? And I didn't call the state out, I just called the states in, like, hey, 5 of you aren't, you know what I mean? And so a couple came up to me, and one state said, our peer said that they don't want it. So I think we can't say that it shall be, but we have to hear from the communities, how do they want to do it, versus saying, well, this should say, all states. Maybe it shouldn't, but we should understand why states aren't doing it. At Inseparable, which is where I work, we have Hopeful Futures campaign, and one of our Hopeful Futures campaign partners, let me tell you, Hopeful Futures campaign is about school mental health. They were very interested in youth peer support, and I heard somebody talk about that earlier. I don't remember who it was, but they actually took a look to see where are youth peer supporters, and are they billing Medicaid? What does that look like? And so this came for the Center for Law and Social Policy, which is one of our HSC partners, our CLASP. And their report was released just recently in 2023. And basically, they found that 18 states allow for Medicaid billing of youth peer supporters. Now, the recipients of those peer supporters varies for state to state. So for example, for some states it can be 18 to 26. For some states it's below 18, with the lowest being 13. Pennsylvania, for example, is 14. So there's still some variability, and I think that's something we need to keep our eyes on and need reporting about. The other area is, crisis. So we would have you listen to her, but we're going to go ahead to make sure we have time for Q&A. But where are peers being utilized in crisis? You can listen to my podcast if you, okay, shameless plug. But anyway, so we also want to have a better understanding of what are the rates that states are using, and who's engaged in a mental health crisis response. And again, we're finding some variability here. And the biggest issue here is that the states sometimes don't know how to use the peer supporters. We have practice guidelines from the National Association of Peer Supporters that says peer support is voluntary. Well, if you're in a hospital involuntarily, does that mean that you can't have peer support? Does that mean peer supports can't practice there? What does that mean? And so we also need to continue to provide clarity to the states about what is the scope of our practice, especially in crisis settings or when people are under involuntary holds and the like. All right, so here's some of our barriers. I'll just run to it. And I like hurdles instead of barriers because I used to be a hurdle runner, if you could imagine that. And hurdle running is very strategic. You just don't run and jump over the thing. You have to know kind of what is, you have to know your stride and all that kind of stuff. So one of the things where we're looking at more guidance is from CMS, particularly around age and prior education. So CMS says, actually, they're silent about age, but what happens is states interpret that the age must be 18 or above because CMS says that you have to have a high school diploma or equivalent. High school diploma, 18. So that's what happens. But they didn't say that, but that's where we go. Also, high school equivalent the equivalency, people go to GED. You don't need a GED. It can be whatever the state says is the equivalent. So I think we need some clarity to the states from CMS about some of those criteria. Also, we need to think about career ladder. Some people come in and they don't move. And so what's the incentive to come in if you actually can't move up into some kind of career ladder? Supervision, again, CMS provides guidance around supervision, and that can be interpreted very linearly as far as a qualified behavioral health provider is what they say has to be the supervisor. So you could actually write that a peer supporter is a qualified behavioral health provider, so a peer supporter could be the supervisor. Right now, it's licensed professionals who know nothing about peer support, so they're turning out many clinicians and people are operating out of their scope of practice. If we want to achieve the outcomes that are on that page, which is reduced hospitalization, longer tenure in the community, having a better understanding of how to move forward in your recovery, if we want to achieve those outcomes, we have to be operating within that scope of practice. We have variable wages. It's all over the place. Rates are ridiculous all over the place, from the lowest around, I believe, let me see if I can find my notes. I'm not going to be able to find my notes quick enough. But the highest rate, I believe, was $24.36 per 15 minutes, and that was in Georgia. Of course, because they've been doing it, I think, since 2019, I believe. And then, I'm sorry, they've been doing it far longer than that. I don't remember the actual year. But the lowest rate was $7.83 per 15 minutes. That's a wide variability for billing on the very same code, which is a H038 code in general. Okay, what is the other? Oh, and then we actually need more data, again, about the wage, who are they, where are they, what are they doing, and stratifying that information. We need to think about telehealth and technology. We've actually advanced in California digital health navigators, and those are peers. Part of our core competencies, we've added 2 to the national ones, which are digital literacy and cultural, not just cultural competency, but structural competency. So we also need a SOC code or a standard occupational code. We are under community health workers, again, which just confuses people. Community health workers and peers are a different profession and scope of practice. I know I'm running out of time, so I think that is, and there is a new bill I want folks to be aware of, which is the Providing Empathetic and Effective Recovery Peer Support Act. And the goal of this bill is to enhance the recognition of peer support professions, eliminate barriers, and do things like create that distinct standard occupational code, codifying the Recovery Office of SAMHSA, and researching hiring barriers and provide evidence-based solution to our hiring barriers. I'll just run through that. And then I provided these resources for you at the end, and I always like to end on, be good trouble, be necessary trouble. That's what we need in this profession. Thank you.
Thank you all very much for your comments and thoughts on the workforce development for mental health and wellness and addiction. We are going to have a very quick, albeit important, conversation about mental health and wellness workforce here. And I'd like to kick things off by asking a pretty general question. One thing I heard from all of you all is that it's an all-hands-on-deck situation. We need everyone. And when we think about the different varieties of, the alphabet soup of doctors and LMFTs and therapists and peers and behavioral health support specialists, how do you all imagine creating a pipeline for those patients who are in treatment to actually navigate the different alphabet soup that we have, particularly when we think about scope of practice, when we think about who shows up when and where and how, and when we think about things like reimbursement and how might we be able to manage that from a policy perspective. Not that that's a lot, but
I can share one way we do this, and it's really a principle of ours, is to look at functions. Number one, you have to engage with the person, and then try to collaborate with them, talk with them, and look at kind of the resources we have, but what functions are needed. And then, as I had kind of outlined, who can perform those functions? So if it's psychiatric medication management, who can perform that? If it's psychotherapy, if it's peer support, or if it's health education, there may be some functions that are shared by a group of people. And then we have to look at who has the best connection with the patient, what can be reimbursed, et cetera. So for us, it's been very useful to focus on what functions are needed to help partner with this patient or consumer. And then let that guide who on the team can perform those functions.
Yeah, I guess I want to add a couple of thoughts. One is I love team-based care. This is what I do. I still think it's really important that someone does own that primary relationship with the patient. And I think there's a tension between task sharing, which, you know, I'm a big fan of, and like that person feeling like they're just being passed from person to person. So I think there's a really important function of thinking about somebody really owning that primary relationship with the patient that we need to think about as we expand the workforce. And being intentional about that, I think, is important. I also have been thinking a lot about how do we educate our patients about who are all these different people they might encounter. And I've been thinking more and more around like maybe some kind of matrix that has like functions like this that we could put up in public spaces so patients could also be a bit more informed about who are the people that they're working with and what can they ask, you know, what things can that person be helpful with. So I think those are really important things for us to think about as we expand that workforce, because I don't think it's straightforward, and it's hard to be strategic, you know, and use everybody at the top of their license and not have 20 people, you know, in that experience feeling very disjointed for the patient.
Now, I'll just add that, you know, I worked at the LA County Department of Mental Health, which is the largest public mental health service provider in the country, and we had chiefs of each discipline. So I was chief of peers and allied health professions. We had a chief of psychiatry, a chief of psychology, a chief of nursing, social work, and psychiatry. And we were the office of the chiefs, which sounds really weird, but you know what I mean. Well, they said chiefs of disciplines, and that scared everybody. But the reality is that we also helped all 6,000 of our employees understand those functions and how to think about what is the role, what is the function, and then also explaining that to the peers. But we had to the people receiving services, but it was constant training too, because people would fall out of scope really easily, and then sometimes there would be this tension about, you know, who gets to be that primary person. And so I was, you know, thinking during that time about that therapeutic alliance, which Dr. Pincus, I believe, talked about. The importance of therapeutic alliance. Who has that strong alliance with the person? Don't break it because that person is supposed to be the person who's the lead. It has to be the person whom they have that alliance with.
As we think about therapeutic alliance, I often think about, you know, sort of the difference between treatment and wellness. And I really think about peers in that particular just sort of paradigm. And if we're thinking about how do we develop the workforce to move people from treatment to wellness, how do you think peers could be involved in that?
I mean, I think peers are critical, and, you know, just from my own, you know, personal experience, I actually didn't believe recovery was possible, primarily because I did not see people who look like me, like up on stage talking or, you know, giving presentations at even at peer conferences or recovery conferences. And so I thought, well, if we're not up on stage, but I see all of us Black people like in the audience, I have to wonder, is recovery really possible? So the minute I sort of brought that up, somebody introduced me to Miss Jackie McKinney, who lived all the way across country, who's a person who started the National Consumer Survivor People of Color Network. And when I met her, that's when I was like, oh, wow, I could do this, and you did that, and how did you do that? And so it became a partnership. It's not an either or, but it's really about that partnership to help a person be able to better articulate what are their life goals, and how do those life goals and recovery goals align also with their treatment goals. So it's this both and. So I have a hard time with like treatment and wellness. I mean, treatment should be about wellness and you know what I'm saying? So I think, again, helping to utilize that peer to do some of the translation. You know, it's like we have a certain way of just talking in everyday parlance about sort of what's important to us that turns into a treatment goal, but we don't understand that it's a treatment goal. So how can you use the peer supporter to do translation back and forth between the person receiving services and the treatment team, and the treatment team back to the person receiving services?
I think that ties in nicely to something Teresa Wynn was talking about earlier, was really when you find those peers, you're really finding the people who are next in line for becoming part of your long-term workforce, and I think that that's super important. I know that I'm looking through the audience. We've got a short time left. Is there any question from the audience? Up front. You want to borrow this one?
I guess 3 comments. It's been really impressive about how the sort of the peer support concept has been sort of systematized and so forth. What about the other categories of people?
Yeah.
Just thinking about the, behavioral health care managers or case managers, the other types of categories. Has there been any further evolution of the specification of these categories and of the functions, so to speak, an ontology of functions that's been more universally accepted? Number 2 is I'm familiar with the IAP program in the UK that you talked about. One of the concerns about that is that one of the good things about it is it's very much integrated into the overall National Health Service. And so they're linked to specific GPs. Which is a good thing, but one of the concerns about it is that it has resulted, from some perspectives, in de-skilling the GPs with regard to behavioral health, because they simply send people over to IACT, and so that's, sort of another, issue. And so it comes back to the question, is there any kind of sort of universal standardization of these categories, sort of as has been done with peer support?
I mean, I know for community health workers and promotores, as those are also being advanced, I would say even more rapidly than peer support these days, that we're starting to see more standardization in those areas where at first community health workers said they didn't want that. So now there are some certifications and trainings for community health workers and promotores. For case managers, I am really not that familiar if it's as standardized and if the workforce actually wants to move in that direction. So I don't, maybe you all are.
I guess I'll say that I do think having payment models has forced some definitions around that. For example, for the collaborative care codes, those are based off of the behavioral health care manager's minutes. So there's a list of things that they could actually do. And I mean, I don't think that that's perfect, but I do think it has been an example of, and Medicare purposely defined that pretty broadly, that it has to be somebody with behavioral health training and I think a bachelor's level degree, for at least for FQHCs and RHCs. It's complex, but I think that's been helpful in that there was some room there to have a variety of people, if they can provide those tasks, actually be able to receive reimbursement for that, which is a step in the right direction. Do I think it would be helpful to have more definition? Probably. I mean, curriculum are wildly different across all of the training programs, and they're old. I mean, I'm just going to say they have not progressed, and I couldn't understand that for the longest time, and then I started talking to people, and it became really clear to me as soon as I talked to some of the programs that offer these degrees, is that every time you change one of your classes, you have to go through the whole certification process to be able to offer that degree again, and so that's a huge limitation in people innovating or moving their curriculum to catch up with the way we're delivering care these days. And so it's really interesting to think about some of those tensions and how they're limiting us in being able to move our workforce forward.
So I think we are past being out of time. So thank you all for beginning this very important conversation. Thank you so much.